So on this themed podcast today, I'm really pleased to be welcoming my friend, urologist Professor Axel Merseburger, who's the professor and chairman in the Department of Urology at Lübeck in northern Germany. Axel, thanks very much for joining us.
Declan, thanks a lot, and thanks for inviting me to Australia. Honored to be here at your great conference. It's been a fantastic time.
So we're here at the USANZ, the Urology Society of Australia and New Zealand annual meeting down in Adelaide. It's summertime here, so it's a nice break for you to come down and have some summer at this time of the year in February. And we're doing this as one of our themed podcasts. Regular listeners and viewers will know that GUcast is supported by a number of different industry partners who are interested in GU oncology, one of whom are Mundipharma, who support Eligard, leuprolide, here in Australia. So what we want to talk about on today's podcast, Axel, is an area I think is very important. It's about, for us urologists and radiation oncologists, medical oncologists, who are starting patients on ADT because they've got a patient with metastatic disease, presumably. How important is it that we know what the testosterone response is? The goal of this treatment, of course, is to bring testosterone very, very low. We've known for many decades that this strategy of effectively castration, having extremely low testosterone levels, is effective. But do you routinely check testosterone when you've started a patient on ADT?
Well, Declan, I think we should test more often testosterone. We check too rare. In clinical trials, this is like set at this point where we have to check, but in routine clinical practice, even though in the situation where you have a failure of therapy with rising PSA or progression on imaging, we tend to forget the testosterone. And I think it's good that you test testosterone on a regular basis, and I do it every second time. So even though the PSA is stable, which also I think confirms that the treatment is working very well, and there's some data that shows when you have very deep testosterone suppression, this is associated with better response, better prognosis in advanced prostate cancer, and this has been explored with Eligard since years, ever since it was introduced to the market. And I think this was quite exciting because looking at the ADT, and they are not all the same. So we have differences amongst the ADTs, not only antagonists and agonists, but also within the agonists, we have the ones with a long stable formulation with a very deep testosterone suppression over months for those products.
Yeah, I agree with you. And I suppose in the early days of using this, or certainly in my early experience as a urologist, all we understood was that it just has to make sure it's castrate, right? There were these, FDA labels or other labels to say you must ensure your product gets to castrate levels. So I suppose we kind of presume if that drug is on the market that's exactly what will happen. But it is important that we know, number one, that it has reached those castrate levels. But as you point out, there is data to say the lower the testosterone gets, the more likely we are to get a better response for patients. So what I used to not check testosterone until the PSA started rising in the future, and you think, they're becoming castration resistant. But now I routinely, actually I do it every time a patient's coming back for a PSA, because I'll forget, did I do it this time or the last time? But I check, number one, when I've started the patient, to say, well, let's make sure there isn't an issue with did they get the injection correctly or this or that? Because it does happen. I'm sure we all have stories
definitely
where something's not quite right. The PSA is not as low as it should be, and the testosterone is still normal or close to normal.
Right.
So I think it's important to check it. But the depth of suppression, I think, is what is an emerging topic of interest. So what are your views on the patient who gets a really deep suppression of testosterone versus one who kind of just about meets the criteria for being considered castrate?
So I think the criteria, just to summarize, but correct me if I'm wrong, I think it's 0.5, and everything less is considered to be castrate. And then we have this new EAU definition, less than 0.2, which for me, if I have patients even going much deeper than 0.2, this confirms the efficacy of this treatment. So you have the backbone, you have it stable and it's working. And I think then we have to discuss what's top or next. So in metastatic disease, it's not enough to just have this suppression of testosterone. They need an ARTA on top, like NHT combination or even triplet, what we've discussed today in this breakfast symposium. But I think coming back to the testosterone, I like your way in testing it every time, and this is a good sign for us as treating physicians, but definitely also for the patient. If you have a very low testosterone, that you're sure this ADT is working.
Yeah, I totally agree. And you mentioned we're now in an era, of course, when we're starting patients on ADT, that for the vast majority of them, they will benefit from adding in something like an AR pathway inhibitor. And we've talked about this on the podcast a lot in the past. It's still a very hot topic in 2024 as these drugs like apalutamide, darolutamide, and so on are becoming reimbursed around the world. We understand that the vast majority of men starting ADT will also be starting an AR pathway inhibitor. And you've published some very nice data, again, on our theme of low, very deep suppression to show that very good PSA responses, the deeper the better, correlate with a better outcome. Can you talk to us a bit about that?
That's in fact interesting, and the question is, does it correlate with the testosterone? And we have to explore this. But coming back to the recent publication it was a post hoc analysis out of the Titan trial, and it's quite interesting. I mean, Simon Chowdhury was looking at this with a low PSA less than 0.2 and could show that the patient that got this very low PSA had the best prognosis. And then we even digged deeper. We looked at the super low or ultra low PSA from less than 0.2 to 0.02 or even less. And we could show that this group of about 60% patients that achieved the super low or ultra low PSA had the best prognosis. They had an overall survival of more than 90% after 5 years. So this is convincing. So if you have this controlled testosterone and a very fast PSA drop within the first 3 to 6 months, you can assure to the patient, or you can for yourself as treating physician, that you have a very safe situation and a very good prognosis. And the question what we haven't answered, but this would be something we could maybe explore together, does it correlate the super low testosterone and the super low PSA in combination with this doublet therapy, in this case with apalutamide and ADT treatment?
Yeah, exactly right, because it may well be that there are disease-related reasons why any level of castration may provoke a great response to these patients. So if then we've had a patient on ADT, we've been monitoring the testosterone, we've had a good response both to PSA and testosterone, but you find that it's not that, it just about meets it, or I sometimes see if it's a patient who has just about reached castrate levels, PSA has had a good response but not super deep, and then I check it again, it's still only around the same. There's no data to say switching from one type of ADT to another or to surgical castration makes a difference, but do you have any views on switching from one ADT to another?
Yes, what we do often when we have this primary metastatic symptomatic patients where we need a fast ADT, sometimes we start with an antagonist then switch towards an agonist after the first 3 months, just because of comfort, because of 3 months or 6 months or yearly formulation. And the other situation where you have those thresholds not really met, what do you do? If the PSA is dropping, everything is fine, but I double check the application. So if everything, I don't know, do you give the ADT yourself?
Not usually, So it's a nurse or a primary care physician.
So maybe double check if everything was prepared correctly. Formulation, this could be an easy error
to
be ruled out. And the other thing would be, in case you don't have a good response in testosterone, I've already switched. I've did this before in some patients where I suspected that this ADT didn't work, so I switched mode of action and another product, and then I would say in 80% of the patient I got the goal. I got the testosterone suppressed. I don't know, real experience on that?
Yeah, look, I agree with you, but even as you speak, Axel, I'm reminding myself that it's only in recent years that I started taking an interest in testosterone. I think for very many years I just watched PSA for the vast majority of patients, and general well-being, quality of life, and in a moment we'll go into and talk about, managing quality of life a little bit for these patients. But I never really looked at the testosterone. And that's why we wanted to talk about this on the podcast today, because there's a lot of urologists and radiation oncologists who listen to this, who I bet you were just like me a few years ago, not really any interest in the testosterone. It's very easy to tick the box on the blood slip to say, see you in a couple of months, do these blood tests, and look at the testosterone, because I think, number one, the patients you've just started, you want to make sure that there's no uncertainty that this patient is castrated, and so therefore is going to get a maximal response. Number two, I am more interested now in seeing how deep is that response, and is it correlating with the PSA, because I think for sure on PSA response, we always want to see a deep response. We've known that for a long time before. If they get below 4, that's good, but if they get below 1, that's much better. Depth of PSA response clearly matters, so it makes sense to me at the very least to make sure that we're getting depth of testosterone suppression in these patients. And before we move on and talk about just managing, I mean, it's great to say we're going to get these testosterone very low, but we do need to manage quality of life impact of ADT. But before we do that, just to talk about castration resistance, or as we begin to suspect castration resistance. So for me, my metastatic patients who've had a very good response, I'm normally seeing them every couple of months with a PSA and a testosterone while they're responding very, very well. And then once I see any sort of change in the PSA begins to rise, and the definition of CRPC still requires 3 successive PSAs rising, separated by a week or 2, I can't remember. So I usually give the patient a few blood testing slips, absolutely include testosterone, because we need to still make sure. And I say, why don't you do, these 3 blood tests over the next, do them separated by 2 or 3 weeks, and let's have a phone call again in 2 months' time or so. So in other words, the message is, once you see that PSA starting to rise, you definitely need to switch into, is this patient becoming CRPC mode? And so So do you do something similar, or once you get a sense of it, do you check PSA more often right from the get-go, even when they're sensitive?
I think what you said, first, it runs by autopilot somehow, but when it comes to the situation where you have a rising PSA, you need to be alert. And I think then you need to think like, how can I help my patient? So it starts from bone protection in this situation. So we need to invest more in the bone, especially when you have bone metastasis. And we've seen this abstract at ESMO showing a value of bone protection also in the stage of MHSPC. If you have heavy bone metastasis, you also, so we've talked about this abstract, which leads into like earlier bone protection, not only in MCRPC as recommended by the guidelines, but once we touch so once we touched MCRPC, bone protection plays an important role.
So like denosumab or zoledronic
acid, I think it would be good. The same thing accounts for HRR mutations. We have the PARP stories. We have the approvals depending on where you live for combination regardless of testing or with testing. So I think at this point, from the transition from MHSPC to MCRPC, it's a good point to discuss HRR testing for your patients. And the third thing is to discuss imaging to see if you have progressive disease aside like the PSA progression, and then discuss augmentation or switching of the treatment.
That's a really good point about imaging. So if you've got a metastatic hormone-sensitive patient, let's say they were de novo, they turn up with a PSA of 50 and they've got some bone mets. In Australia, it'll be on a PET scan because everyone gets initial staging with a PET scan. So they've had a great PSA response, but do you do routine imaging in these de novo metastatic patients? Do you do like a CT and a bone scan every 6 months, or do you wait for PSA rise or symptoms?
You could potentially wait for PSA rise. I feel safer to do the imaging really depending on the patient profile. I discuss it with the patient, allude to the guidelines, but I want to have an imaging at least once a year, because we all know some cases where they develop neuroendocrine differentiated tumors and then you have no PSA response or signal, and liver mets progressing, and you see the clinical progression and the patient comes to your office, PSA is still like within like 4 or 5, very well suppressed with your doublet therapy, and then you have progressive disease. So then the patient is in a very desperate situation. So I think every half year in this metastatic situation is well invested imaging.
And conventional imaging, like a CT and a bone scan.
Depending on the reimbursement, in Germany we don't have all the reimbursement for PSMA and all indication for PSMA PET as you have here in Australia, so we still rely on conventional imaging. And I think once you have metastatic disease and you have proven that you see it in conventional imaging, it's not a mistake to continue.
I totally agree. And just to clarify, in Australia we have reimbursement for initial staging.
Okay.
And then we have
not for follow-up.
No, not for treatment response or follow-up. And then we have a separate indication for biochemical recurrence after primary treatment, so after radiotherapy. But what we don't have is reimbursement in the metastatic patient just for disease assessment or response assessment, not even for selection of radioligand therapy.
So that's conventional imaging.
Yeah, but because PET imaging is quite affordable in Australia, relatively speaking, sometimes people will fund it. But like a message I have for people is, there's real value, I think, in doing conventional imaging in these patients we're just speaking about. CT and a bone scan every 6 to 12 months, and then again at progression. And I think conventional imaging is important. Finally, Axel, thank you for all your time. So accepting that these men with metastatic cancer need to be treated with ADT in a doublet, because the overall survival benefit is so good, as you've lectured us about a few times this week. What's your thoughts on managing the side effects of ADT, the very predictable quality of life impact on well-being, hot flushes, fatigue, and so on, weight gain? Do you have strategies that you can point your patients towards or support in Germany for these patients, like exercise and so on?
Honestly, it's not really so easy. It's the same as convincing patients or ourselves to lose weight. It's not that easy. It's really tough. Like exercise, as you mentioned, makes sense. Sometimes even acupuncture is recommended by some guidelines and has helped the patient. What we use medical-wise, like supererone acetate in case of hot flushes, like steroidal anti-androgen, sometimes works, and the rest, I think, sometimes the time solves. Like it's initially they get bothered by the hot flashes, but I think if they get adjusted, the man, usually it works. And again, bone protection is important, especially bone-associated loss, and we have an indication for denosumab half yearly in this bone loss indication. So I think it is important to educate the patient, and also we have patient educational material for that, what they can do, and special diet and patient-informed groups. I think this is important to motivate your patient to use app, to go for that on the internet, to get information on what to do to prevent or to support your well-being under ADT.
And I'll give you one final tip on it. We have a wonderful podcast, friend of the podcast, called Tim Baker. He's an Australian patient who is a writer, and he has written an amazing book about his experience of starting ADT when he was
he had ADT, yes,
age 49, age 49 with metastatic prostate cancer, and because he's a journalist himself, he's a really, really beautiful storyteller. But he wrote this book called Patting the Shark, and it's all about his experience with ADT. This is a few years ago, and we've had him on the podcast, actually supported by our friends at Mundipharma again. And he's in this book, he describes the strategies he developed himself to support the quite devastating, in his experience, effects of ADT.
So teach me, what was his
so he got these, and I'll send you a link. We'll put a link in the show notes for this one. But he's got 4 things, right? He calls it MEDS, MEDS. Meditation, exercise, diet, and sleep. So in the book he talks about how he himself figured out that meditation, and we've put some links to apps you can do yourself. Exercise, because it's well established, the role of it, and he's a surfer. He's actually he's Australia's leading surfing journalist. He's written lots of books about surfing and so on.
Love to meet him.
Yeah, he's a great guy. And diet. So he took on to himself to say, right, that can really improve my well-being. So he's really interested in this, and not like being super restrictive, but just having a healthier diet. He thinks helps to mitigate the side effects. And sleep. He experienced a lot of sleep disturbance early on. The other one that's not mentioned is the whole sexuality issue as well. And he is quite critical of the medical industry. He's grateful to the ADT, don't get us wrong, but he's critical of us in perhaps not addressing, especially in the younger patient, the impact of this on sexuality. Yeah, because of course we're going to have fatigue and we're going to have this and that and the other. Maybe it's out of an era when we were unfortunately expecting these patients to have a poor survival, just a few years. Now they're going to live a lot longer, and if you're a younger patient, like he's 7 or 8 years out from his diagnosis now, and he's actually on intermittent ADT, his PSA is still down, he's going to live a long time. And so sexuality as well, and we recently had a podcast with my intimacy specialist, Victoria. She runs a great resource called A Touchy Subject. So when you Google A Touchy Subject, and it's all about the journey of sexuality beyond prostate cancer treatment, so not just surgery, radiotherapy, but also including the devastating effect of ADT. So we'll put the links in the show notes and I'll email them to you, but these are great free resources and podcasts for people.
I like this 4 ways in overcoming this ADT related situation. I just thought of myself with my jet lag now. I think I will do the same: meditation, good food, exercise, and then sleep.
Yeah, so as opposed to eating too much, maybe having a few late drinks with me, etc. That's probably not good for it. Axel, thanks so much again. That was really interesting. I learned a lot from you, and thanks very much to our friends at Mundipharma, our silver partners, for supporting these initiatives, and thank you for being here in Australia.
Thanks a lot. As said, I learned a lot from you.
Thank you.
I connect you. Thanks.